And what we learned from this trial was that in the case of T-cell mediated rejection, either diagnosed by histology or by molecular microscope, the Prospera show decrease of the percentage of donor-derived cell-free DNA, right? So, but in the case of antibody-mediated rejection, we did not see such great effect. Some tendencies there were clear, but not such big effect.
Hi, I'm Dr. Phil Gauthier, a transplant nephrologist and medical director at Natera. For today's episode of our series, we're joined by Professor Ondrej Viklicky, who is a transplant nephrologist and the director of the transplant program at IKEM in Prague. Dr. Viklicky is going to discuss with us research he's presenting here at the ATC in Philadelphia regarding the ability of Prospera to monitor treatment response in both ABMR and TCMR. He will also discuss how he uses Prospera in his transplant program in Prague to assist with patient care. And finally, he'll describe a case in which Prospera was very useful to detect rejection. We hope you enjoy this episode. Good morning, how are you?
Very well, thank you, and very grateful that you invited me to speak about.
We're very happy that you're here. Are you enjoying the conference so far?
Yes, conference is great as every year. So it's far away from Europe, but it's worth it to come every year.
So let's talk about your transplant program. So can you just tell me about your transplant program, how it started, when it started, how many transplants you do?
Yeah, so our transplant center is located in Prague. The institute is called Institute for Clinical and Experimental Medicine, and this is a pioneer institute in the Central Eastern Europe for transplantation. So we were the first who performed the kidney transplantation and on 21st March 1966.
Wow.
So that was the original start.
Before I was born.
Yeah.
Barely.
Me too. So that was quite a historical time. So right now we are considered as one of the largest European transplant centers with some 300 kidney transplants performed a year, 150 liver transplants, about 40 to 50 heart transplantation, and 30 to 40 pancreas transplant. Our surgeon, they can do also the small bowel transplant, but it's also quite rare, one per year. Also, they performed the uterus transplant, but it was more experimental than clinical. But for the clinical routine, more than 500 transplants a year it's done in our center.
Wow, that's very busy. And do your patients come from exclusively within the Czech Republic, or do you get them from outside as well?
No, it's not possible. They need to be registered in our waiting list, the national waiting list of Czech Republic. We have 10 million population. We do like 2/3 of all transplant performed in our country. So we have basically patients from our capital, Prague, nearby, but virtually from the whole Czech Republic if they ask us to take care about them.
And do you follow them for the rest of their lives, or do you have other providers take care of them afterwards?
This is a very good question, because we have right now 3,000 patients living with a functional kidney graft that need to be followed by us, nephrologists.
That's a lot.
So that's a lot. That's a lot, and we also would like to do the nephrology care. So we need to manage something also in the near future, but what we do right now is that we follow them forever, but we do not follow them every 3 months, especially if they live outside and they need to travel. So we also ask our local nephrologist colleagues to share our care. So but at least once a year we see all of these patients, right? So if they live around the Prague, so then we follow them regularly every 3 months. If they live outside and they need to travel 3-4 hours, then we decided, okay, it's better if you stay home and you travel to our center just once a year. But the patient is then followed by the local nephrologist, and we implemented all methods of telemedicine, that we communicate with them. We have a transplant coordinators that call patients. Patients can call transplant coordinators.
That's great.
To really manage the care And we also implemented the patient's applications into the mobile phones, so they are connected to our center, that we can just give them the notes that there is a vaccination time, or if we change the visit, we can send them prescription via this mobile phone. So they are more and more connected using these new innovative approaches.
Right.
So it's much easier for us than it was before.
That's great. I know in the U.S. many non-transplant nephrologists use Prospera to help them understand which patients are doing really well and which ones need to be sent back to the transplant center. Have you considered using Prospera in that scenario?
Yes, I guess this is a very good example how it can be used later after transplantation.
Exactly.
And then the only question is who will perform the test, or if they can just send the tubes to us,
Right.
from outside. So everything is possible in the future.
So I'd like to talk to you today about Prospera, our donor-derived cell-free DNA test. I know you're very familiar with our test. So do you mind starting off by telling us how you first found out about Prospera?
Yeah, the first time when I heard about Prospera was some 4 years ago in the US conference here, but also because of my contacts with Professor Phil Halloran, when he invited us to participate on his trifecta studies. So that was the first time when I have heard about the Prospera, and since then we got in a very good contacts with the people from Natera, and then also supported our own research at IKEM with prospective trial and the effect of treatment trial, so which is going to be presented here in this conference.
Oh, great. So why don't you tell us a little bit more about that research that you're presenting today?
Yeah. So we are presenting in our poster the effect of treatment in the view of Prospera trial, of Prospera test. So what we did, that we enrolled about 42 patients who experience acute rejection diagnosed by histology.
I see.
But we also performed a molecular microscope in those patients. And then we follow them regularly, every week. And we measured the Prospera test in prospective way. And what we learned from this trial was that in the case of T-cell mediated rejection, either diagnosed by histology or by molecular microscope, the Prospera show decrease of the percentage of donor-derived cell-free DNA, right? So, but in the case of antibody-mediated rejection, we did not see such great effect. Some tendencies there were clear, but not such big effect. My explanation of this difference was that while the T-cell mediated rejection treatment is well established and known, and we need to target the T cells, the treatment of antibody-mediated rejection is not well founded, and many people try to use plasmapheresis, IVIG, steroids, but in fact we do not yet target the cause of antibody-mediated rejection. And funny thing is that we did not see the effect of decrease, of real decrease of cell-free DNA, which reflects our negative experience with the treatment of antibody-mediated rejection.
So the patients didn't respond to the treatment, and they also didn't see a decrease in their cell-free DNA post-treatment for ABMR.
Yeah, absolutely.
I see.
Absolutely.
Okay, and did they respond clinically at all?
Yeah, well, while in the TCMR, we observed the decrease of creatinine. This is nice. In antibody-mediated rejection, we are happy if the creatinine is stabilized, right? But probably just a very small proportion of patients had some decrease of serum creatinine and improvement of renal function. So usually we are speaking about stabilization rather than improvement.
And could you talk a little bit more about molecular microscope? Because I'm not sure everyone in the audience may be familiar with that concept.
Yeah, molecular microscope is innovative diagnostics that using assessment of thousands of genes and RNAs within the tissue And molecular microscope can, in some cases, better respond what's going on in the graft.
Right.
While the histology may have got some problems because of the accuracy of the sample, the molecular microscope can diagnose the disease, the rejection, in a much better way. So, for example, for borderline changes that Banff defined as no rejection, molecular microscope in some cases found TCMR, and in some only non-specific changes called no rejection. So in these cases, we do not treat these patients. So also the vascular changes like V1 scores sometimes are not associated with rejection despite the classification as a rejection 2A. So it means that using the molecular microscope, we can get rid of unnecessary treatment in these cases.
Right. And if I recall, there were some cases that were called no rejection by BAM, but then the molecular microscope discovered that these patients actually did have rejection. Is that true?
Yeah, this is true, especially in highly sensitized patients.
Right.
When we perform the transplantation across the HLA barrier, what we found that within the first week when we perform the biopsy, then when the kidney is not working, and there is only ATN by histology. So when at the same time, if we got the answer from molecular microscope, we find out that this is early active antibody-mediated rejection that need to be treated immediately.
Right.
So this is the real advantage of this molecular assessment, that is that you get the answers ahead of the visible damage by histology.
And in your research, how well did cell-free DNA correlate with the things that you see on both regular microscope and molecular microscope?
In our research, there was a clear association not only by histology with the decrease of cell-free DNA, but also with molecular microscope. So we divided this assessment based on the histology and based on the molecular microscope, and based on the molecular microscope we observed the same. But what was the most interesting thing is that in some histology, the molecular microscope found no rejection. And in those patients with no rejection, there were also no increase of cell-free DNA.
Ah, interesting.
So that was a very nice correlation.
Great. So going back to treatment response, I think you had another poster where you looked at the effects of daratumumab on ABMR. And can you talk a little bit about that and how Prospera performed in that?
Yeah, that was a very interesting case, because within the last year, we heard a lot about the possible effect of anti-38 treatment. There are 3 monoclonal antibodies available. So in Prague, we had the opportunity to get daratumumab. And that was a case of 4th transplant. So highly sensitized, highly immunized patient who had the chance to get transplant because of his flow cytometric cross matches were negative ahead of transplant, despite the low level of DSA. What happened after transplantation was that there was a very rapid rebound of DSA associated first with subclinical and later with clinical antibody-mediated rejection that was diagnosed by histology, by molecular microscope, and also with significant increase of the portion of cell-free DNA.
Okay.
So because it was the 4th transplant and we used everything before, to treat this antibody rejection, since the 3 months after transplantation, we decided to treat patient with daratumumab. So he received a little bit reduced dose for another 6 months. And after the 6 months, we performed the control biopsy. What we learned was that there is no signal by histology for antibody-mediated rejection, but also no signal in MMDX. It means no signal in molecular microscope. So it was completely cleared, yeah, it's disappeared. But also cell-free DNA decreased.
Great.
But because we were so afraid of the rebound of DSA and the rebound of rejection, we monitor patient later on. And then previously we were used performing protocol biopsies in such cases.
Right.
But now with Prospera, what we did, we just monitor the Prospera test.
I see.
So we see that after the termination of the treatment, at 3 months, at 6 months afterwards, the patient is still stable and the Prospera test is negative. So it means we do not need to ask patient for permission for another biopsy.
Well, that's great.
And we use this excellent negative predictive value of Prospera test to see, okay, there is no rejection, so please be happy, and as we are happy, and we just continue the monitoring.
And actually, that's a great segue, because I was going to ask you about our recently published paper, the proactive paper showing that Prospera increases in advance of rejection. So can I ask you what you thought of that paper?
Yeah, I think this is a very important paper, and it's nice that this now is broadly discussed in the transplant community, especially because of its it's called is proactive, but it's preemptive definition of rejection. I think that is when we get the answer many weeks ahead of the real injury, that is measurable by histology or by serum creatinine, and we will have finally the treatment of this disease in the case of antibody-mediated rejection. So it's very important that the biopsy then is performed earlier, the treatment is performed earlier. Yeah? So I see the proactive study as a very, very important tool for monitoring of high-risk patients, but is for monitoring clearly, for repeated assessment, while our case can show the Prospera in view of eliminations of unnecessary biopsies in the case of high-risk patients, when we need also to perform repeat biopsies, repeat evaluations.
Yeah, I imagine it's useful that the Prospera goes up 5 months before ABMR and 2 months before TCMR.
This is really unbelievable. But probably we will need to do the biopsy and even the molecular assessment to learn again if there is, because what may happen, I think we do not have data on this preemptive biopsies when the Prospera is positive. So we do not know yet whether the biopsy will show any sign of rejection, or maybe the molecular assessment by molecular microscope will give better information to us that there is ongoing process that need to be stopped before the injury within the defined by histology is happening.
So let's then shift gears a little bit and talk about how you use Prospera clinically in your practice. So can you tell us how you use it and what kind of impact that's had on your patients and your practice?
Yeah, we have been using Prospera within the last year.
Okay.
So of course we have some limits from our hospital officials. So because when I heard first time about the Prospera test, I saw, okay, that will be great for monitoring, so repeat and repeat assessment. But right now it's not possible because of clear burden. But using this negative predictive value, this extremely high negative predictive value, we can really use it in patients who are at the high risk of rejection, in the cases of HLA incompatible transplantation. That in our center we have like 6% of our patients receive the transplant across the HLA barrier, and those patients are subject of repeated biopsies. Repeated biopsies. So now with Prospera test we can just monitor the negative value means no biopsy, and we can tell patient, okay, you are fine, and we can just follow you, and we will repeat the test in 6 months, for example, if nothing happened.
I see.
Yeah.
So how much have you reduced your usage of biopsies, would you say?
I think we have a plan to establish the Prospera test in the future to replace our protocol biopsies that we regularly do at 3 months. It means at our center 300 biopsies, because we are the high volume center with some 300 biopsies a year, with 300 transplant a year.
Okay.
And when we performed the protocol biopsy once, so it means 300 biopsies.
So it sounds like you'll be able to avoid almost all of those 300 biopsies by using Prospera.
Yeah, but not only us, but also many other centers in the Czech Republic. As in our institution, we do like 2/3 of the kidney transplant, and 1/3 is done outside in other small centers. So when we apply for regular reimbursement of cell-free DNA tests, that is possible that we avoid not only 300 protocol biopsies in our center, but another 200 biopsies in other centers. So it's a quite huge volume. So I believe that we spare not only money, but also we improve the quality of life of our patients.
Yeah, sure. And it's great that you're confident that a negative Prospera really means you don't have to do the biopsy.
Yeah, so if we know that the negative predictive value is nearly 99%,
Wow.
in some trials, 95% officially, I guess. So it means that we can really rely on this test, and I think it's safe to use this non-invasive assessment. Right now, we use it in patients who has got transplantation across the barrier, either ABO or HLA.
Right.
And then we perform still the biopsy at 3 months, but afterwards, at 6 months or at 12 months, when the creatinine it's a little bit moving, so then I think it's much worth it to use the Prospera test to be sure that then there is no real injury, and this is something that is a pre-renal AKI or something like that.
Right.
It's not necessary to perform biopsy. This is maybe the future also in the transplant monitoring.
Great to hear. So tell me about this case. I understand you had a paper accepted this morning. Congratulations.
Yes, thank you.
Based on a case that you experienced. Can you discuss that?
Yeah, that was the case with the daratumumab treatment. And this patient, that was the fourth transplant, as I already said. Yeah, so this was this case, but I can repeat it. This was the case when the patient received the fourth transplant.
Okay.
Because of they were HLA antibodies before the transplantation, but flow cytometry was negative, so we proceed with transplant. But because of a great rebound of HLA antibodies that happened after transplantation, there was in histology and clinically antibody-mediated rejection that we had to treat with plasmapheresis, with IVIG, even with rituximab. But because we were not successful with this treatment, and in protocol biopsies we saw the ongoing injury, we decided to treat patient with daratumumab, and we treat the daratumumab for 6 months. And after 6 months, we performed the control biopsy, and we learned that there is no rejection, no antibody-mediated rejection, no molecular signals, because molecular microscope was negative as well, and cell-free DNA decreased. But after we stopped the treatment, we continue to observe the patient, and we ask ourselves if we need to perform other biopsies to be sure that there is no rebound. Not only there was no rebound in anti-HLA antibodies, but also no other injury ongoing within the graft. So, but we replace the histology for Prospera test, and this is how we use it. That we use this negative predictive value for avoidance of unnecessary biopsies in these high-risk patients, and we are repeating this approach in other patients with the similar problems.
Great. And is that patient still doing well today?
Yes. I'm so happy that he is now more than a year after cessation of daratumumab, and he's still perfect. In fact, I saw him last week before I traveled here, and he was perfect.
Great. Well, that's really great to hear, and it makes me very happy that our test was able to help you take care of this difficult patient on their fourth transplant, no less.
Yeah,
that's amazing.
Yeah, we have some of these patients, as we have the quite large transplant center with a long history of transplantations. It means that we have also a lot of patients in the waiting list who wait for retransplantation, not only second, but also third, fourth, and some 5 transplants.
Well, thank you so much. I really enjoyed our time. Is there anything else you wanted to tell us about, or?
No, I think I'm really grateful that you invited me to speak about our patients, our experiences, and it was really nice speaking with you today.
Great. Well, thank you for coming.
Thank you.
Thanks so much for joining us for this interesting conversation. I hope you enjoy it as much as I did. Don't forget to subscribe to be notified about our next exciting episode. Thank you.